Today we will discuss two important topics. One is pharmacoeconomics and another is pharmacogenomics. So these are part of general pharmacology and they mainly cover different aspects of the pharmacology. So pharmacoeconomics first we will discuss. Pharmacoeconomics, that means economics about the pharmaceutical products or pharmaceutical services. So how, when we are giving some medication, for example, for some disease, we have to choose the medication whether the medication is cost effective or cost beneficial of the patient or for a group of patients or not, because this is needed for the policy making of the country, policy making of the state or policy making of a single hospital also. So when we have to indent some medications for a hospital, we have to see whether some medications can be obtained in lower cost and that can be supplied to the different types of the patients in the minimal cost. So that will cater a large number of the patients. This is in simple terms. So there are different types of the pharmacoeconomic analysis through which we can determine whether for a particular group of patients a particular pharmaceutical product or some health services is beneficial or not economically. Okay. So first, characteristics of the formulary management. When we are managing a formulary of a hospital, for example, there is a hospital, we have to manage the formulary, what medications should be there. So we have to choose the drugs. So you know about the Me Too drugs, there are different types of the similar drugs by different brands. So there are, for example, proton pump inhibitor, there are different types of the proton pump inhibitors are there. Different groups of drugs, for example, there are omeprazole, pantoprazole, lansoprazole, etc. For each group, there are different types of the brands, there are generic products also. So you have to choose according to their efficacy, safety and tolerability. This is the first one, whether the drug is efficacious or not in that particular patient population, whether this is safe or not, adverse drug reaction, any history of adverse drug reaction or it is minimal or not, and tolerability, similar whether it is tolerated by the patients or that group of patients or not. But not only this is not only the one thing that should determine how to choose a drug or choose a health service, whatever may be it. There is another thing is the humanistic outcomes, whether that pharmaceutical product or health service improve the quality of the life of those patients or not. That is also important. Quality of the life, and lastly the cost considerations, because there may be some improvement or some advantage of drug A over the drug B, but drug A is very much costly than the drug B. Then there is problem, even if the patient is prescribed drug A, the patient will not continue. For example, for some chronic disease, there are drug A and drug B. Drug A is advantageous to drug B, but the cost is quite high, but the patient needs to continue the drug. So it has been seen by research that if we are giving the drug A, the patient will not continue it. After some months, the patient will stop. But if we continue the drug B, in the long run, that will be beneficial for the patients. So this is cost considerations, and ultimately that will also improve the quality of the life of the patients. So the pharmacoeconomic evaluation is done. It is an evaluation that considers both the effects and the cost of the two or more alternative choices. Effects means consequences and outcomes. So pharmacoeconomic analysis is a part of the outcomes research. Outcomes research means we are basically concerned with what is the outcome of giving some health service or some giving some medication or some attaching some devices like that. So whether the consequences, whether the outcomes, whether it is what the rupees that is spent on that patient or not, and the two or more alternative choices. So there are alternatives we have to choose. So we have to evaluate economically about this. So it is defined as the comparative analysis of alternative courses of actions in terms of both their cost and consequences. This is the definition given by the Drummond. So basically there are alternative courses of action. Courses of action there may be some operation also. So some bone fracture is there. There are two types of the operations. Some operations may be more costly, some may be less costly, some may be some advantageous, some may be less advantageous. There may be some health service. For example, you are giving some vaccines in the population. So all these comes under the purview of the pharmacoeconomic evaluation. So there are options. So we have to choose economically whether in terms of their cost and also the consequences. What will be the outcomes and also cost? Both should be statistically interpreted. So there are different types of the outcomes. The most common we know about this, the medical outcomes, which is the end result of the medical care. That may be positive. For example, using the right antibiotic to treat an infection, that may be negative. Wrong antibiotic to treat an infection, that will not heal the disease, and also there is resurgence of the resistance. So there are indicators, different types of the surrogate markers are there from which we can determine whether the treatment we are giving that is ultimately give rise to some meaningful medical consequences or outcomes or not. So it is a measurable unit that provides information regarding the outcome of interest. For example, during the hypertension, we can measure the blood pressure, systolic blood pressure, diastolic blood pressure, that can give rise to the idea about the hypertension, and in the long run that can also give an idea about the heart conditions, whether there may be some heart ailment or not. In the long run, that may also indicate there may be increased chances of the morbidity or mortality or not. Okay. So medical outcomes is determined by the eco models. Eco means economic, clinical, and HO means humanistic. That is, quality of life is also important. The patient is given some drugs, but the quality of the life is not improved so much, or the quality of life is deteriorated, that also should not be there. So eco model is to be kept in mind when we are choosing, or in a for a group of drugs or for a group of health services, which is given to a group of patients or a single patient. Clinical outcomes may be cure, comfort, or survival, depending upon the disease. So there may be some end stage cancer where we want to just increase the survival, or we want to for a good quality of the life for the rest of the life that the patient will spend, like this. If there is some infections, we should determine the outcomes according to their cure, comfort. For example, there may be different goals. The goals are different for different diseases. Humanistic outcomes is the quality of the life. Quality of life means there are different types of the domains, like physical domains, emotional function, social function, role performance, pain, etc. So all this should be taken care of. For example, a patient with rheumatoid arthritis, the patient is of very severe excruciating pain that is hindering his or her normal daily life. So his or her normal quality of life is compromised. His or her physical functioning is compromised. That also gives rise to some emotional problems also. So all this should also be taken care of. Economic, lastly, expense savings and cost avoidance. So what is the expense? Direct expense to the drug, direct expense for the hospitalization. What are the savings? If we are choosing the another thing, whether there is any savings in comparison to the another or not. And cost avoidance. If we are choosing a different part, there may be some avoidance of the cost. For example, we are giving a drug that may be somewhat costly, but that drug ultimately decreases the chances of hospitalization. Another drug is there, very minimal cost, but there is chance that the patient will be hospitalized every 2 or 3 years. So ultimately, we should not only taken into consideration the cost of the medicine, but also indirect cost, like cost of the hospitalizations. Okay. This is the economic evaluation. So these are some examples. For example, hypertension. This blood pressure is the indicator, surrogate marker, which is measured by the sphygmomanometer, systolic and diastolic blood pressure. That may give rise to the clinical outcomes, like long term. In the long term, there may be some renal failure, there may be stroke, myocardial infarction, or ultimately death can also be there. Humanistic outcome, quality of the life, whether there is any compromise in the quality of life of that patient or not. So economic outcome, this can be measured like cost per decreased millimeter mercury blood pressure, cost or per stroke avoided, or cost per life year saved. That is, this can be calculated statistically. So what is the total cost, for example, in 10 years if the patient is taking this medication, and for a large number of the patients we are following up, and we are seeing that if it is not given statistically, we can avoid this number of the deaths. So life years saved, what number of the life years saved. Similarly, what average decrease millimeter mercury of blood pressure, like this. Hyperlipidemia, LDL level, similar thing, that ultimately gives rise to clinical outcomes like myocardial infarction, there may be angina, ultimately death, quality of life, cost per myocardial infarction avoided, or cost per point decrease in LDL. For example, in diabetes mellitus, HbA1c and the blood glucose levels, also in the long term that may give rise to the retinopathy, nephropathy, there may be cardiac disease, nerve disease, all this can happen. So quality of the life, whether there are quality of life questionnaire is there, whether that is compromised or not. And economic outcome is measured like cost per change in HbA1c. That is 1 degree change in the HbA1c, what will be the cost? Cost per kidney transplant avoided. For example, asthma is similar, it is measured by this forced expiratory volume, peak flow meter, etc. can be used. Exacerbation, what are the chances of the exacerbation? This drug is given, another drug is given. So cost per symptom free day, this is needed because asthma ultimately in all of the cases it is not life threatening, but ultimately that decreases the quality of the life. Because of the asthma, the quality of the life is diminished. So again this can be evaluated. So we can compare the cost and consequences or outcomes of the two or more alternatives. What I am discussing, for example, this is the choice. This is for program A, there is cost A, for program B there is cost B, and there is consequences A, there is consequences B. Program means that may be health program, that may be single drug given for a single disease, there may be some vaccination, that may be some operation, two types of the operations, anything can be happen. So there are two alternatives, for example. So there are different types of the evaluation by these two alternatives. For example, whether we are comparing two or more alternatives or not, and whether both cost and consequences of the alternatives are examined or not. This is in simple terms. When we are not comparing two or more alternatives and we are not examining cost and consequences. Here we can examine only consequences, that is we are giving drugs and only the outcomes is measured. What will be the outcome? So this is basically a simple outcomes description. We are giving the drug, what will be the outcome? How much blood pressure is diminished, like this. When we are examining only cost, that is the cost description. That is the cost of drug A is this, cost of drug B is this. We are giving this drug without evaluating any consequences. So this is outcome description, this is cost description, okay. But when we are examining both the cost and consequences, but we are not comparing, this is the cost outcome description. That is, this is the cost of drug A, this is the cost of drug B, this is the consequences of drug A, this is the consequences of the drug B. But we are not statistically evaluating this. When we are comparing these two or more alternatives and cost and consequences are measured, this is known as the clinical trial. In the clinical trial, basically we are comparing one to another. There may be cost analysis, only cost analysis, when we are analyzing the cost and we are comparing between the two alternatives. But when this cost consequences both are compared and both are examined, that ultimately determine the full economic evaluation, full pharmacoeconomic evaluation. This is done, and there are different types of the processes by which this pharmacoeconomic evaluation can be done. So these are the main four types by which pharmacoeconomic evaluation can be done. First is the cost minimization analysis. Here the cost is measured in monetary units and outcomes is equivalent of that. Cost effectiveness analysis is used in monetary units cost and outcomes is measured in the natural units, that is units of that disease. Cost utility analysis, again the cost is measured in the monetary units and outcomes is measured in the quality adjusted life years. That is, the health related quality of the life is mainly examined in cost utility analysis. And in the cost benefit analysis, both the cost and outcomes or consequences are measured in monetary units like dollars. That is, these consequences or outcomes are also statistically interpreted as how much the cost is saved or how much cost is ultimately done. So ultimately they are compared. So this is in simple terms the main four types of the pharmacoeconomic evaluation: cost minimization analysis, cost effectiveness analysis, cost utility analysis, and cost benefit analysis. So first coming to the cost minimization analysis, it examines only the cost of competing technology. So competing technology cost is examined and how much cost is minimized when one or another is used, that is basically analyzed. So it assumes equivalent effectiveness. So we are first assuming that the effectiveness or last consequence is equivalent for this drug A and drug B. And then we are comparing the cost and how much cost A minus cost B, how much it is minimized. So in normal terms, where this type of analysis is usually used, it is usually used in different types of the brand medicines versus generic medicines. For example, in some hospital supply, whether we are procuring some branded medicine or we are procuring some generic medicines. So here we are assuming that both the branded medicine and the generic medicine, since the drug is same, the consequence will be the same. Again, then the branded medicine, for example, one tablet price is 20 rupees and the generic medicine one tablet price is 10 rupees. Since the consequence is same, so we can say that the cost minimization is 10 rupees per one tablet if we are procuring the generic medicine instead of the brand medicine. Okay. So this is the example. Or two or more drugs in the same therapeutic class with similar side effect profiles. Same therapeutic class, me too drugs, the side effect is similar, we know from the different clinical trials. So here we are assuming the consequence or outcomes is same, then we are evaluating this. So net result is usually expressed as cost per patient treated. What are the number of patients treated and what is the cost? For example, these are the different types of the drugs. We can say this comes under the same group of drugs. You read about this. This is the sulfonylurea used in the treatment of the diabetes mellitus. So for example, this is the different types of the group of drugs and this is the cost. Some changes, some is 22, some is 29, like this. Okay. So here we can say this is here we are assuming the consequences of reduction of the blood glucose level or the reduction of the HbA1c level is similar for all these drugs. Now the cost is, some is 22, some is 29. So we can say that this drug, the first drug and the fourth drug is quite less in comparison to the other drug. This fifth drug is more less, 20. So just minimization, cost minimization analysis. But the problem here is, in many of the cases, this branded medicine, generic medicine, but different groups of medicine, the effectiveness is not similar, and that can also be tested. That should be tested in clinical trials. So that is the problem with this. Next, coming to the cost effectiveness analysis, we are saying in layman terms that this is cost effective. So this part, this thing is cost effective to this thing. What is this? Here costs are measured in physical units and valued in monetary units. So effectiveness is measured in natural units of health improvement like clinical outcome measure, years of added life, prevention of event, for example this. So outcomes must be measured in the same units to compare interventions. For example, again in case of the diabetes mellitus, drug A and drug B, drug A, this is the cost, drug B, this is the cost, and the consequence is how much blood glucose is diminished. Drug A, blood glucose is diminished average this, drug B's blood glucose is average this. So again, then we are evaluating the cost and the consequences. Here cost is in the monetary units and the consequence in the natural units. Natural units means units of that disease. That may be disease, that may be life year saved, that may be number of the strokes prevented, that may be number of the myocardial infarction prevented, like this. So results are expressed as cost by effect, like $100 per 1% reduction in HbA1c for the diabetes. So in the after evaluation, we can say that if we are using drug B, that ultimately needs $100 per 1% reduction in HbA1c, and for the drug B, that may be $120 per 1% reduction in HbA1c, like this. Similar, $50 per 10 milligram reduction in LDL. Example, $5 per symptom-free day gained in case of the asthma or chronic obstructive pulmonary disease. So this is the cost effectiveness analysis. So here incremental cost effectiveness ratio can be analyzed by this TC1. TC1 means total cost of treatment for drug 1. TC2 is the total cost of treatment for drug 2. So we are just subtracting it and we are getting the value, and that is divided by the effectiveness of the drug A minus effectiveness of the drug B. Effectiveness is measured, for example, how much the HbA1c decrease, how much blood glucose is decreased in case of the diabetes mellitus. So by this we can get the result of the two drugs, and then we can say that this drug A is cost effective in comparison to the drug B, like this, or this type of the health program is cost effective in comparison to the another type of the health program. So this is cost effective analysis or cost effectiveness analysis. So here the cost is expressed in monetary units and the consequences are expressed in the natural units or the disease units or the number of the life years gained, number of the strokes prevented, number of the myocardial infarction prevented, like the example what I am giving. So drug A total cost for 100 patients. So 100 patients we are procuring this drug, for example $10,000, and the effectiveness, it has been seen that when we are using this 10 strokes are prevented. For the drug B, total cost for 100 patients is approximately $60,000. Here the effectiveness is 50 strokes are prevented. So by just seeing in the naked eye, we cannot say whether this drug A should be procured for a hospital or this drug B should be procured for a hospital. In the layman terms, we can see that this is quite high, but the more number of the strokes are prevented, but it needs statistical analysis. Okay. So you can say when we are statistically evaluating, it has been seen that cost per stroke prevented for drug A is the $1,000 and for the drug B is the $1,200, that is more. So when we are evaluating this, we can say that this drug A is cost effective to the drug B. So in the layman, in the naked eye, without statistical analysis, we can say that this drug B may be more cost effective to the drug A. But when we are statistically evaluating this by giving that formula, we are seeing drug A is in fact more cost effective in comparison to the drug B, not the vice versa. So this is an example. So incremental analysis, incremental cost effectiveness analysis is needed. So this is the additional cost that one service or program imposes over another compared with the additional effects, benefits or utilities it delivers. So ultimately this is the definition. Next, coming to the cost benefit analysis, cost benefit analysis. Here the resources consumed and the health outcomes both are measured in monetary units. So when we are decreasing the HbA1c, when we are decreasing the blood glucose level, that is also converted to the monetary units, that is how much rupees is saved. Again it is done by means of the statistical modeling. So both cost as well as the consequences that are in the monetary units and then it is compared. This is known as the cost beneficial approach, and from this we can say that drug A is cost beneficial in comparison to the drug B. So the previous one is the cost effectiveness, this is the cost benefit. Okay. So decision rule, choose the treatment with the highest net benefit. So results, benefit minus cost is the net benefit, because both are expressed in monetary units, so we can just subtracting it. So when we should accept the programs with net benefit, that is when it is the ratio is greater than 1. Ratio greater than 1 is beneficial aspects of the monetary units is more than the consequences aspects. When it is more beneficial, that means greater than 1. When it is less beneficial, it is less than 1. So we should accept some drugs or we should accept program whose this benefit by cost ratio is greater than 1. For example, benefit per cost is the net benefit and net cost. The same thing. So the same thing, I have already given example. Another example is, for example, in case of the hypertension, we are measuring the blood pressure level and we are seeing that this cost of the drug A that decreases the blood pressure level for 1 month for 100% is this, and for drug B is this. Now the average, the decrease of the blood pressure is this for the drug A and another is the drug B. Now that can be statistically evaluated to see whether that decreases the chances of the death from the hypertension in the long run. That may be for the drug A this is and for the drug B this is. That can again be converted to monetary units, that whether there is some death or there is some hospitalization, there may be some assumption that this amount of the money can be spent for the drug A and can be spent for the drug B. So the consequences and the cost both are then expressed in the monetary units and then it is compared. Then we can say that the drug A is cost beneficial to drug B or the vice versa. So this is all different types of the mathematics and statistical modeling. Okay. Next, coming to the cost utility analysis. Here the resources consumed are measured in monetary units, again the monetary units, but the outcomes are mainly measured in case of the quality adjusted life years, that is health related quality of the life. This is not in the clinical outcomes or not in the monetary outcomes that is changed from the clinical outcomes. It is measured in case of the quality of the life. So, quality of the life based upon the utility, that is the patient preference. So, utility, what is this utility? It is the value or what placed on a level of health status or improvement in health status as measured by the preference of individuals or society. For example, the patient is suffering from the asthma or COPD, there is severe dyspnea, the patient cannot go to the work. So, there may be some work days lost. So, that can be calculated. For example, in 365 days, the patient is suffering from asthma attacks, for example, for 50 days. Within the 365 days. So, 50 days, what is the average income of those group of the patients, we can determine if the patient misses this 50 days, what is the consequences of that. So, again that can be incorporated this. So, health related quality of the life can be measured from this. So, the cost analysis framework is done by the study perspective, what are the resources consumed, valuation of the resources, and lastly the sensitivity analysis. This is all statistical terms, details is not required. So, to conclude, the pharmacoeconomic analysis is the valuable tool to answer a clinical question, whether that is cost effective or not, whether it is cost beneficial or not, or whether it is more cost utility or not, and the quality of the life. But there are always limitation of the modeling. So, all these are assumption or all these are different types of the resources and researches based on mathematical and statistical modeling. So, sensitivity analysis, in the previous we have seen the sensitivity analysis should be there. That is, for the small group of patients, different pharmacoeconomic trials and researches are continuing for the different types of the drugs or different types of the programs, and from this we can say that this may be this is more sensitive or this is less sensitive. Applicability of the study data to the individual patient is again that is controversial. Basically, we are averaging this by means of the sensitivity analysis. So, for an individual patient there may be change. For an individual patient, his or her income, his or her socioeconomic status, his or her disease status ultimately dictate what the drug should be given. That drug may be very costly, that drug may not be cost effective or cost beneficial, but for that single patient that may be needed for that patient. So, this is mainly utilized for a group of patients or in case of the policy making. So, physician factors are already there. So, this is more or less about the pharmacoeconomics. So, next we will discuss about the pharmacogenomics. So, within the pharmacoeconomics, you have to read what is pharmacoeconomics, and there are mainly 4 types by which the pharmacoeconomic evaluation is done. The first is the cost minimization approach, the second is the cost effectiveness approach, third is the cost benefit approach, fourth is the cost utility approach. Okay. So, you have to read whether full kore dao na eta ageta prothomta. So, you have to read about this because this pharmacoeconomics comes as a short note and some part of the long question is also there, very common. And this next coming to the pharmacogenomics, again the short note and part of the long question is also very common for this. So, now coming to the pharmacogenomics. So, previously we have seen about the cost, now we are moving towards the more targeted therapy, pharmacogenomics, where the genetic factors or genes are also incorporated in dictating what drug to be given to a patient. So, basically this is a more patient oriented matter, because ultimately that leads to more effectiveness of the drugs and less adverse effect, because till now we are giving some drugs blanketly. So, this disease we are giving some drugs blanketly, but we know there are minute changes in the genetic makeup of each individual. So, ultimately that dictates, already we have seen that there may be changes in the metabolism of the drug, there may be changes in the distribution of the drug or elimination of the drugs based on the genetic makeup. There may be some drug-drug interaction or drug-food interactions that may be more in some patients, that may be less in some other patients. So, if we can capture this more and more with the coming years, more and more genetic makeup, if it is incorporated in the treatment, that leads to more effectiveness of the treatment and less adverse effect. So, this is the basic tenet of the pharmacogenomics. So, what I am saying, that we are prescribing one of the several appropriate drugs, but we are basically giving the drugs based on the weight, sex and age, adjust the dose over time, and whether the patient is responding it to or not, and whether the patient is experiencing some adverse drug reactions or not. Only this we are considering. So drug presently what is available is one size fits all. So for this disease we are giving this drug, but they don't work the same way for everyone, what I am saying. So a drug that is safe and effective for one patient may prove to be dangerous or ineffective in another. So that is the problem. So also it is difficult to predict who will be benefited from a medication. So there may be chances of the adverse effect, there may be chances of the inefficacy. So the same antibiotic can work for the same type of the infection in one individual, in another individual that drug will not work. So there may be some resistance in that. So and some other patients there may be some adverse drug reactions. So currently there is no simple way to determine whether the people will respond well, badly or not at all to a medication. So by simply looking or by simple blood test or chest X-ray or ECG or echocardiography, we cannot determine that what we are giving this drug, whether the drug will be beneficial to that patient or not. Adverse drug reactions is quite common and that may also lead to death. And the main problem of the adverse drug reactions is we cannot determine that this same drug for the same disease can give rise to the adverse drug reaction in one individual but not in the another individual. So different patients respond in different ways and ultimately there is variability of their genetics that ultimately determine this. So genetics can account for approximately 20 to 95% variability into drug disposition and effect. So pharmacokinetics and pharmacodynamics already we have read. Already we have seen that there are different types of the genetic changes, for example cytochrome P450, already we have seen cytochrome P450 levels change due to the genetics and ultimately there may be less metabolism for some drugs, more metabolism for some drugs. So there may be, if for some patient there may be more metabolism of that drug, the drug will not be effective, and if there is less metabolism of that drug, that drug may lead to adverse drug reaction. So that is the problem. So inter-individual differences in the drug response, that is the problem, and drug metabolizing enzyme, drug transporter, drug targets, all these are basically proteins. You know that this is the drug target, for example the G protein coupled receptor, all these are different types of the proteins. So these are dictated by the genetic codes. So ultimately there is minute changes in the genetic code, so the drug disposition, drug targets all are somewhat different from one another. So inherited determinants generally remain stable throughout a person's lifetime. So if we can capture that this is the genetic makeup and we can give this drug is beneficial, that is quite becomes a targeted therapy. So the way a person responds to a drug is a complex trait that is influenced by many different genes. So there is not just one gene. So without knowing all of the genes involved in drug response, it is difficult to predict a person's response to a particular drug. So we know there are some variations, small variations in the nucleotide or DNA content, and these variations we want to capture. So pharmacogenomics is a science that examines the inherited variations in genes. Variations in genes that is inherited that dictate the drug response, and thus exploring the ways these variations can be used to predict whether patient will have a good response to a drug or a bad response to a drug or no response to a drug. So this is the definition of the pharmacogenomics. So we are examining and utilizing the genetic inherited variations in genes, that is the genetic code and genetic backup, to determine whether the patient will respond to the drug or will not respond to the drug, or if there is some adverse drug reaction when we are giving that drug. So you know about the chromosome, genes and DNA. We are not going into the details. You have already read in the biochemistry what is genes, genome, what is the genetic sequencing, etc., etc. So these are the genes. You know this is the chromosome, centroid, spindle, how the gene, what are the different types of the genes, and you know that each chromosome carries a couple of thousand genes. Many of these are common to all human beings. So 99.9% of the DNA is identical to one another, but there is slight change in the 0.1%, and this 0.1% influence the differences between the height, hair color and also the susceptibility to the particular disease. So there is minute change in the genetic makeup. So this is the DNA double helix structure, how these two helixes are there, how the genetic makeup is formed from the DNA, you know about this. Now coming to the genetic polymorphism. Polymorphism means changes. Poly means many, morph means form, changes in the form. So polymorphisms are a type of genetic diversity within a population's genetic pool. So within a, for example, in South Asian population, so we can determine the common average genetic makeup for in South Asian population. What is this? So this is the polymorphism. So there may be some changes that is quite common in this ethnicity that is not present in another ethnicity. So this drug may be more beneficial for this ethnicity, not beneficial for another ethnicity. So that we can determine by examining this genetic polymorphism, and more genetic polymorphism are getting acquainted with we are now. So they can be used to map or locate genes such as those causing a disease, and they can help match two samples of the DNA to determine if they come from the same source. So depending on its exact nature, a polymorphism may or may not affect the biological function. That may happen. So polymorphism means a variation in the DNA that is too common to be due merely to a new mutation. So continual mutation is going on in our body in a genetic pool, but if there is some variation is there that is too common to be due merely to a new mutation, that is a common polymorphism. So it is usually determined a polymorphism whose frequency is at least 1%, that is greater than or equal to 1% in the population. So one type of the gene that is present more than 1% in some population, that is the genetic polymorphism changes of that population. So some drugs may be there that may not be effective in that population, or some drugs may be effective in that population, not effective in some other population. That may happen. So genetic polymorphism, we can say that genetic polymorphism for this ethnicity, if it is present, for example, this ethnicity contains approximately 5 lakh people. In 5 lakh people, greater than 1%, they have this genetic polymorphism. For example, some TTA polymorphism is there in chromosome 5, more than 1%. Then we can say that this is genetic polymorphism for that ethnicity. Polymorphism is common in nature. It is related to biodiversity, genetic variation and adaptation to the environment. So it usually functions to retain variety of form in a population living in a varied environment, and polymorphism basically results from evolutionary processes for the different types of the species, and it is heritable and is modified by the natural selection. Again, some polymorphism it is not needed for the natural selection, that will be removed in due course. Then polymorphism, then the next is the single nucleotide polymorphism, that is very important for this pharmacogenomics. Single nucleotide polymorphism or SNP, also known as the SNP, it is a small genetic change or variation that can occur within a person's DNA sequence. So single nucleotide polymorphism means only a single nucleotide. This is a DNA sequence variation that occurred when a single nucleotide A, T, C or G in the genome sequence is altered, and this alteration again it is present in greater than equal to 1% of the population. So these snaps occur every 100 to 300 bases along the 3 billion base human genome. You know our 3 billion base human genome in our body. Therefore, millions of the single nucleotide polymorphism must be identified and analyzed to determine their involvement if we have to sequence some drug. So that is the problem. So a single base change, if it is found in at least 1% of an ethnically diverse population, it is known as the single nucleotide polymorphism, because it is easier to diagnose, only a single change, single nucleotide polymorphism. So DNA is essentially a chemical operating system for the body. So you know that mainly determine our different phenotypes, genotype determines our phenotypes. Genes can determine how a person reacts to a medication. So a genetic variation that makes the drug to stay in the body longer than normal, causing serious side effects, or a variation that makes the medication less potent. Already you have seen the same thing, the metabolizing enzyme that may be more effective in some individual, less effective in another individual. So once a variation is identified, scientists might be able to match it up with response to a particular medication and then develop a personalized approach to medication. So personalized approach. So we are moving towards more a personalized approach rather than a blanket therapy. Okay. So pharmacogenomics, again basically this is a study of how an individual's genetic inheritance affects the body's response to drugs. Genetic inheritance determines the body's response to drugs. The term comes from the words pharmacology and genomics. So it is at the intersection of the pharmaceuticals and the genetics. Pharmacogenomics combines pharmaceutical sciences with knowledge of genes, proteins and single nucleotide polymorphisms. Proteomics is also an important thing. So it is a branch of pharmacology which deals with the influence of the genetic variation on drug response in patients by correlating gene expression of single nucleotide polymorphism with a drug's efficacy or toxicity. So both we are seeing whether the drug is effective or not, whether the drug is toxic or not, or whether there is any action or not. So it combines genomics, proteomics with the medicine. So ultimately the goal is to develop an effective safe medication and doses that will be adjusted according to the person's genetic makeup. So ultimately it answers the following questions like, why does a drug shows beneficial results in one and the same drug was intolerable for others? So already we have discussed, why does some need more the standard dose of the drug to be effective, more potent drug. For example, some patient their fever subsided with paracetamol 500 and for another 650 or 1000 milligram is needed. Why does some need only half of the standard dose, less dose is needed, otherwise there may be problem. Why do some people get cancer, anti-cancer drugs, that is throughout about the different types of the genes. Cancer again, because the anti-cancer drug, many anti-cancer drugs acts on according to their genetic makeup. And also why some drugs shows more compliance, that is the patient is there may be no problem in taking a medication for a long period of time, there may be less adverse effect. So that is the compliance or adherence to medication, that is also changed according to. So ultimately we want to develop an optimal drug therapy for maximal efficacy and minimal adverse effect. So this is the important, that is why time and again I am saying. So it holds the promise that the drugs might one day be as per each person's own genetic makeup. This is the long term goal, future goal. So it is a science examines the inherited variation in genes that dictate the drug response. Already we have said about that ultimately determine whether there is good response, bad response or no response at all. There may be another term known as the pharmacogenetics, which is basically a part of the pharmacogenomics. So pharmacogenomics is the general study, while the pharmacogenetics is the study of the inherited difference of variation in drug metabolism and response. So a part of the pharmacogenomics is the pharmacogenetics, whether we are basically studying the inherited variation in the drug metabolism and response. So the distinction is basically arbitrary. Now the two terms may be used interchangeably also. So when there is a difference in sequence of the genes or genetic variation or polymorphism, more commonly the single nucleotide polymorphism, that ultimately dictates the different types of the enzymatic activity, drug metabolism, drug elimination, etc. Ultimately the pharmacokinetic and pharmacodynamic parameters may be changed. So drug and doses, important example. So getting a wrong dose in case of the leukemia means the difference between the life and death. So that may be a minute change. In the same patients, if we are giving some wrong drugs, the patient may die in case of the cancers. So for single nucleotide polymorphism to be used in this way, a person's DNA must be examined. So genetic pool must be determined. But the problem is traditional gene sequencing technology is very slow and expensive. So all these are very expensive things. Now the DNA microarray techniques have come, or DNA chips, which is an evolving technology that somehow decreases the cost, that will make it possible to examine the patients for the presence of the specific single nucleotide polymorphism. So here already we have pinpointed some single nucleotide polymorphism and some drugs, and by DNA microarray techniques it can be examined. And also scientific research is going on to ultimately determine more number of the single nucleotide polymorphism. So the field of the pharmacogenetics begins with a focus on the drug metabolism first, and that is extended to encompass the drug disposition, transporters, absorption, distribution and excretion. Again the pharmacokinetics already we have seen. Drug metabolism, already we have seen about the cytochrome P450 systems, and already we have read there may be genetic polymorphism in the cytochrome P450 systems. Some may be less active, some may be more active in different individuals in different ethnicities. So there may be some genetic inability to express some functional cytochrome 3A5 example. There may be some individuals or some ethnic groups where this metabolizing enzyme is not present. So in those persons, if we are giving some drugs, that may give rise to the toxicity. Which drugs? Those drugs that are metabolized by the cytochrome P3A5. This is example. The single nucleotide polymorphism also ultimately leads to for example, this cytochrome 3A5, there may be some intronic sequences. So here we can ultimately create a cryptic splice site causing 131 nucleotides of the intronic sequence to be inserted into the RNA, introducing a termination code that prematurely truncates the cytochrome 3A5 protein. So this can be done. So we can change some genetic makeup also by giving some therapy, genetic therapy or gene therapy, that can also be the future. Drug transporter, again the drug transporters order the proteins and all are determined by the genetic makeup. The same thing, these are the examples like P-glycoprotein, ATP binding cassette transporter protein. Again, if there is some changes, the drug will not be transported in the target site, that may be the problem. So the benefits of the pharmacogenomics is ultimately we are going to a more concise and powerful medication. So pharmaceutical companies ultimately want to able to create drugs based on the proteins, enzymes and RNA molecules associated with genes and diseases, both the genes and diseases, and basically on the proteomics and genetics. So it emphasizes therapy to a particular disease and also for a particular person, not only a disease in a blanket terms. This allows the drug makers to produce a therapy more targeted to specific disease. And ultimately drugs are created on the proteins, enzymes and RNA molecules, and that can maximize the therapeutic effects and decreases damage to the nearby cells. Already you know there are different types of the genetic therapies also there are different types of the monoclonal antibodies, and there are some drugs that is targeting some individual with that genetic makeup already is there, but this is quite handful, and with moreover every year some gene therapy, some genetic therapy, some genetic drugs are coming out. So in the future we can see a lots of the genetic therapy, but the problem is again the cost. It is quite costly, but in the future we can expect that the cost will decrease. So rejection of the trial and error therapy, basically we are giving some drugs, if it is not working in that person we are changing the drug. But when this becomes, the pharmacogenomic approach becomes more potent, we can firstly determine that this drug will act. Only that in that case we can give that drug. Exact method and appropriate dose, again we have to increase the dose or decrease the dose. We are giving some drugs, for example in diabetes mellitus medicine, and again according to their blood sugar level we are giving some other drugs or increasing or decreasing the drug. That will not be needed. We are giving from the first the appropriate dose that ultimately maximize the tolerability and minimizes the adverse drug reaction. Specialized screening of the diseases can also be done. So beforehand we can screen the disease according to the single nucleotide polymorphism chain, and beforehand prophylactically we can give some drugs. So in the babies, for example in the children, we can determine that this disease, this type of leukemia can occur after some 10 years due to there is changes in the drug, changes in the single nucleotide polymorphism, and we can give the drug beforehand so that the disease will not happen. So prophylactic use is also important. Better vaccines, again we can develop more and more vaccines. Easier drug discovery becomes easier because we know there is this change in the gene ultimately give rise to the this type of the disease and this type of the changes in the drug response. So just in the retrograde fashion we can search some drugs or discover some drugs that can target those genes. So basically this is a retrograde approach to drug discovery. Easier drug discovery, that is why it is known as the easier drugs discovery, and ultimately that also decrease the cost of the clinical trials, because the clinical trials it is quite a costly affair. It needs a long number of the years, many number of the paperworks, and there are different types of rules and regulations, and ultimately a drug comes into the market. What you are seeing different types of the drugs that ultimately comes from lots of years of the examining and the perseverance. So that will be decreased. Reduction in the healthcare cost, ultimately the reduction in the healthcare cost will decrease because the drug becomes costly, because it needs a long time of the investment. So ultimately if the investment will be decreased, the healthcare cost is also diminished. So barriers of the pharmacogenomic approach is already there because it is still in the infancy. Finding the gene variation, more and more single nucleotide variation by the newer techniques, newer biochemical techniques, newer genetic techniques is to be needed. So application to help in prediction of the exact dose of a particular drug already have decreased to a particular patient, that is for a right drug for a right patient in a right dose in a right time. That is the motto. Most important application is to target therapy to a subset of the disease. there may be some disease, some subset that will not respond to the common drugs. Here the gene therapy is needed to test viral genomics, such as selecting treatment for the HIV based on the resistance. Again, the resistance is quite become commonplace for the viruses, for the bacteria. Here we need this. To a limited degree today, clinical trial researchers use genetic tests for variation in cytochrome P450 genes to screen and monitor patients. Until now, we know something about the cytochrome P450 genetic variations and the single nucleotide polymorphism, and accordingly there may be some changes, but newer and newer, more drugs and more enzymes and the transport proteins need to be screened for the single nucleotide polymorphism. So to conclude, it is basically needed for better clinical diagnosis, fewer clinical failures and faster drug development and breakthrough medication that ultimately reduce the death, reduce the morbidity, mortality, hospitalization, adverse drug reactions, everything. So this is everything about the pharmacogenomics. So in the pharmacogenomics, that can come as a short note, already I have seen, we have to say what is pharmacogenomics, how the pharmacogenomics approach is needed for the exact dose of the drug, for the exact patient, for the exact time period, this is needed. What is the utility of the pharmacogenomics, pharmacogenetics, how the single nucleotide polymorphism can be used in different pharmacokinetic and pharmacodynamic parameters. Okay. So this is about the pharmacoeconomics and pharmacogenomics.